Honorable Chairperson, respected panel of expert, moderator, teachers, and colleagues. Assalamu alaikum and very good afternoon. Today, my topic is fates and facts of a planned to an unplanned game. Let us see the brief history of my patient. A 53 years old gentleman. Risk factors were diabetes, hypertension, CKD, and family history of coronary artery disease. ECG was normal and echo was normal. Ejection fraction was very good. Cardiac troponin, 2 samples, consecutive samples were normal. A patient had thrombocytopenia and his diagnosed case of hepatitis B positive. An initial diagnosis was unstable angina, and I planned for coronary angiogram after hydration with normal saline. Let us see the angiographic view of my patient. Here you can see here, there is a lesion involving the proximal to the mid LED as well as the diagonal 1 and 2, but there is severe critical bifurcated lesions involving the diagonal 1. It was Medina, class 111. And on the other side, you can see here, there is also significant lesion involving the OM, and it's a good size vessel. If you look the right side, you can see here, there's no significant lesion in the right coronary system. So actually, this is not a critical case. I think my fellow colleagues or my colleagues who are sitting in front of me, everyone can do this procedure in a very simple way. But why I intended to present this case in this August gathering? Actually, I feel trouble in every step, starting from the wiring of the side branch up to the delivery of stent to the side branch. So, just I want to share my pain with my colleagues. Let us see what should be the next. Evaluation and management of thrombocytopenia. For this reason, I talked to my two consultant, hepatologist as well as the hematologist. They thoroughly investigate the patients and conclude that the patients had hepatitis B induced immune-mediated thrombocytopenia, and he had early stage of cirrhosis of liver, and fibrous scans revealed that report was 14.7. And next, I talked to the cardiac surgeon as well as the patient and party, but the patient declined CABG. And then we decided for upfront two-stent strategy, decay crash for the LED diagonal, and then stress PCI to LCX to AM. Wiring of the main vessels and wiring was trying to cross the side branch. Multiple attempts to negotiate the side branch, but failed to cross the lesion. And lastly, low pressure balloon dilatations of the main vessel, and it was thought that it might be change the carrying of the bifurcational angle as well as the lumen of the main vessel. As because I tried all the maneuvers, whatever written in the textbooks, but I failed to cross the lesion to the side branch. And later, side branch occlusion occluded totally just after low pressure balloon inflations of the main branch, and patient developed symptoms, but finally, successfully wiring of the side branch after modification of the main branch lesion as well as the carina. Then I go for sequential predilatations of the side branch with 1.5 and 2 balloon at different atmospheric pressure. And then main branch predilated with 3 into 12 balloon, 1:1 predilatations with 10 ATM, but patients suddenly developed severe symptoms and ST went up, and due to acute main vessel closure. You can see here on the left and the right side. So, what should I do now? Should I proceed to the planned decay crash? Or should I proceed provisional single stand strategy plus minus kissing balloon dilatation, or unplanned bailout tap stenting technique? Let us see the procedure. A 3 into 38 millimeter DSC was placed in the main vessel and deployed at 12 ATM, which secured the main vessel patency and to alleviate the life-threatening ischemic symptoms as well as complications. Flow was established at main vessels, but D1 severely pinched as before. Main vessel stent was optimized with sequential post-dilatations with 3.512 NC balloon at different pressure. And then port was done with very high pressure, 20 to 22 ATM, and keeping the gel wire in the side branch. And remove the gel wire, and balloon supported wire across the main vessel stand start. And then sequential dilatations of the stand starts with 1.5 and 2 balloon with 12 to 14 ATM. And then kissing balloon dilatations with 2.515 and 312 NC balloons. But there was significant residual restenosis with osteal dissections of the side branch. Unfortunately, we decided to secure the side branch with stent by tap technique. A 2.5 into 15 DSC was tried repeatedly to deliver the side branch, but failed. Then I took a body wire at the side branch and redo port with high pressure with 3.5 into 12 NC balloon. And body wire and port helped me to deliver the stand to the side branch. And then I advanced the uninflated balloon to the main branch and proper positioning of the stand. This could be done by subtraction stand boost may guide for precise positioning of the stand, as because precise positioning of the stand is the tricky step of T-stenting. And angiography after side branch stent deployment. And deployment stent was seen by stand boost. You can see here the proximal part of the ostium side branch is totally covered by the stent, and the distal part of the ostium there is a slight protrusion of the side branch stent. Pull back side branch stent balloon slightly back into the main branch. And finally, simultaneous kissing balloon inflation after sequential dilatations of the side branch and main branch, and angiography after the final kissing balloon inflation. An angiographic result after the final port. So my take-home message: TAF is a modified T-stenting and is an easier bailout provisional stenting strategy. IVAS OCT is an essential imaging tools for stent optimization, but subtraction stent boost may be a good alternative. Predilatations of main vessel at bifurcation may facilitate wiring of the side branch in a selective cases by modification of the main branch lumen as well as shifting of carina. Port is mandatory, and body wire may help to deliver the stent into the side branch. Planned to unplanned technique may be a game changer to win the battle. Thank you, everyone. Thank you for patient sharing.